So let's move on to Fran, who is our last speaker. Many of you will be familiar with this particular speaker, Professor Fran Boyle AM, and she's speaking on breast cancer recurrence. Fran is a medical oncologist at North Sydney's Mater Hospital, where she's the director of the Patricia Ritchie Centre for Cancer Care and Research and Professor of Medical Oncology at the University of Sydney. Fran was also the chair of breast cancer trials from 2012 to 2015. Hi, Fran.
How are you doing?
Great. How are you?
Well, I'm trying to take on all of Leslie's good advice. Actually, I've just given a talk to the medical students this afternoon at University of Sydney about looking after yourself when you're looking after oncology patients, and there's a lot of similarities, Leslie. So I think probably that's good advice for us all around. I'm trying to work out how to share my screen. We'll get there in a second. Here it is. Go. How's that?
Yes, that looks great to me.
Great. So I've been asked to talk to you tonight about the issue of breast cancer recurrence from a couple of different perspectives. So from a perspective of people who have early breast cancer or are thinking about what do I look out for, and for the people with metastatic breast cancer who are thinking about what's the best treatment for me. So I'm going to try and zip through what's an enormous topic in a fairly short space of time. So let's see how we go. So Raylene Boyle is not actually a relative of mine, but I think we probably came out of adjoining bogs somewhere in the Irish or Scottish wilderness. And she, of course, was a sprinter. And she said to me some years ago, actually winning a gold medal is easy because you know how far you have to run. And the problem with breast cancer is you don't know how far you have to run. If you have early breast cancer, you don't know whether it's going to be gone after your initial treatment or whether you should still be keeping that weather eye on weirdo symptoms. In metastatic breast cancer, you don't really know how long you're going to live. So you don't know how long the track is. Should you pace your energy? So if you're running 400 meters, you're going to be running a little bit differently from if you're sprinting 100. And I thought that was a good description of the issues that we have in managing that, what touched on briefly by Leslie, that fear of recurrence. And occasionally you hear about people in the media who get that magical thing called the all clear. So this is one of my patients, Sally Obermeier, and she's a great supporter of breast cancer trials and of research who had triple negative breast cancer just at the end of a pregnancy. And she was desperately worried that she would not see her daughter's first birthday. And that was a pretty fair concern because she had a horrible breast cancer, and she had lots of chemotherapy and surgery and radiotherapy and all that stuff. And we all got to the end of that first year and breathed a big sigh of relief because she was still okay. Now, that was 2012. So the fact that she's still okay actually probably means she has got the all clear. And what this demonstrates is that the all clear at 1 year is not the same as the all clear 8 years later. And there was no magic about her disease that gave her that magic all clear. And I know your friends and family all want you to be able to say at the end of treatment, I'm done. That's it. You can stop worrying about me. I'm all fine. I got my stamp. I've done the right thing. But it doesn't work that way. And it didn't work that way for her either. It's just that if you work in the media and you want to get a job for the next 12 months, you have to tell people that you're all clear. So the only reason she gets the all clear is that she has to tell people that to stay employed. You probably don't. That's probably a good thing. ultimately. And what about the 5 years? So back in the day, we used to say to people, if you get to 5 years, you're probably fine. You don't need to worry about breast cancer anymore. And although these graphs are complicated, I'd just like to walk you through them, if that's okay. So this data comes from Canada, where they have really good records about who has treatment for early breast cancer and what recurrences they have. And they compared in this study patients who were diagnosed back in the 90s with patients who were diagnosed in the 2000s, when all of the new treatments for breast cancer came into routine use. So aromatase inhibitors, Herceptin, Taxotere, the new chemotherapies. And so if you look back at that earlier group, I don't know if my little pointer works here, but back in the day, those patients who had HER2 positive breast cancer, which was hormone negative, had a very high chance of relapse within that first year or two. And we all have patients who, next to young, but Prue and I would have patients from that era, who had, you know, all of the right stuff done, chemotherapy, etc., and then within 12 months they had a recurrence. Now some of them are still alive because they haven't had Herceptin initially, and they had it when the cancer came back. But that was very high-risk disease. If they were hormone positive, that's the yellow group here, not so bad. And if they were triple negative, kind of similar. Now the hormone positive patients are down here, and again a little bit of an upswing in that first 12 months. But generally, most people have this pretty good downtrend by the 5-year mark. So what did they see a decade later with the new treatments? Well, obviously good stuff. So they showed that the HER2 positive patients, bang, doing much better. Triple negative patients doing much better. So a much lower chance of that early recurrence that we worry about. But what they showed also was that these hormone positive patients in the blue and the yellow, they just kind of jog along. They don't necessarily go away at 5 years. And so what we've started to be able to do is give a message, as Prue said, that's much more nuanced. It's not just, you know, one size fits all. 5 years is not the magic number for everybody with breast cancer. If you have triple negative breast cancer, that's in the red. Sure, if you get to 5 years, the chances of it recurring are very low. Fantastic. But for most other kinds of breast cancer, we still need to keep a watch into that second 5 years, and particularly for hormonal breast cancer, really it's kind of 10 years is the new 5. Now that's really irritating to people who kind of had their sights set on a finish line at 5 years and who were going to stop treatment and it was done and they could put it all behind them. And I'm sorry about that. But this is where data is really, really important. It helps us to know what the right thing to do is to help them in that situation. Now, women also say to us, well, you know, what should I look out for in terms of signs of recurrence? And, you know, you can either take the approach of, if I'm sick, I'll go to the doctor and they'll sort it out. Or you can take the approach of saying, every morning I'm going to check myself from head to toe. And if I don't have any of these symptoms, I don't have breast cancer today. Different personalities, different approaches. So if cancer comes back in your bones, which is probably one of the most common things, it comes back in the bones in the middle of your body. And the reason for that is that those are the bones that have got no marrow in them in the adult. It doesn't come back in your hands and your feet. So if somebody rings me and says, I've got pain in the big toe and I'm terrified that it's cancer, I go, oh, won't be. It won't be cancer below your elbows. It won't be cancer below your knees. That's a pretty good rule. If it's pain in the bones in the middle of your body, okay, let's have a look at that. I've got a headache. It came on the right side at the end of a long day at work. Anna sent me some Panadol. That's not cancer. A headache that's there every morning and getting worse and is associated with a bit of twitching of my right hand, totally different story. Nausea and pain in that, up under the right side of your ribs, that's where the liver is. Most people who have that kind of problem have gallstones, and an ultrasound can sort that out pretty fast. But occasionally that means liver metastases. If you have a cough that doesn't go away, and you're short of breath as well, that's important to check it out. And a lump in the armpit, the axilla, or above these collarbones here. And you'll notice when we examine you in the clinic, we always come straight to the collarbones. And that's because lymph nodes in this area here, not the ones up under the jaw, which come from your tonsils, but just down here, are a place that breast cancer can spread. So if you're the kind of person who likes to check, there are some sensible things to check, and there's a whole bunch of stuff you don't need to worry about. So what does follow-up involve? Well, weirdly, not very much. And the two absolutely key aspects of that are having an annual mammogram, and if you have dense breasts, then an ultrasound. If you've got a particularly weird-looking scar, then an ultrasound. And if you're young and have a BRCA mutation, an MRI. That's really important. And most places would suggest that you have that done in a treatment centre rather than at breast screen. But that's mainly because you get the results much more quickly and you worry less. So breast screening, if that's convenient for you, is a perfectly reasonable alternative as well. Then you have an appointment with your surgeon, if you have an oncologist, with your oncologist. And that's really important as well, because apart from a physical examination, which is like poking your fingers up here, listening to your chest, feeling for your liver, they'll also check how you're going with your treatment, how the side effects of any endocrine therapy going, how you're managing with, psychologically, physically getting over your treatment. So that's really important. It's been tough this year during COVID, not being able to examine people. And we're so glad that they're back in the clinic now. Now that does not mean really intensive testing with blood tests, CT scans, spine scans, PET scans, etc. And that feels weird because the logic is that if cancer was going to spread, the sooner you find it, the more treatable it's going to be. And I agree with that. I think that's completely logical, but it's yet to be proven to be an advantage to women. And in general, we try not to expose women who've had cancer to radiation unless we've got really good evidence that that's going to help them. So one of the reasons that we don't scan you every 10 minutes is that we don't want to radiate you. The other reason is that we know that scanning every 10 minutes makes people anxious. That's not a good idea. So until we've got good proof that that's going to be worthwhile, we're holding off from that. There are special circumstances where it's a good idea. For instance, you decide you want to be pregnant after having breast cancer. And the pragmatist in me says, I don't think I'd want to be pregnant. I knew I'd had cancer that had spread. Let's just do a set of scans. Or I'm going to spend $20,000 on a reconstruction, a 10-hour anaesthetic, a week in hospital. And I'm thinking, I'm not sure I'd spend that $20,000 if I knew I had metastatic disease. So very pragmatic, total negotiation between you and your oncologist rather than something that a big clinical trial is going to answer. But what does the future hold? And I think this is where we're going to make so much progress in the next decade. In all of our clinical trials now, we collect blood for circulating tumor DNA, so that genes in the blood that might show that cancer is still present, for circulating tumour cells, and in some circumstances where people have locally advanced or larger cancers, PET scanning before we start. So I'm pretty sure that the next decade is going to show that there are some situations where we can, say, okay, you're at risk we should be following you up more intensely. You're absolutely fine. Off you go. Don't worry. And hopefully, if you get the money, those things will happen. So what can I do to reduce the risk of recurrence? Well, that information that hormonal breast cancer can come back after 5 years has helped us to identify that in some patients with high-risk features, 10 years of hormone blocking treatment is better than 5. So that's something to talk about with your oncologist rather than assuming it's all going to stop at the 5 years. Very recent results have shown that adding an extra drug to the hormone blocking treatment in those first couple of years can be helpful if we have very high risk disease. That's with a drug called abemaciclib. Not currently on the PBS for this indication, but hopefully that will come. And a similar drug, palbociclib, waiting for further results from trials. So the idea that you might be able to ramp up your hormone blocking treatment early on is certainly one that's being tested. What else can you do? Well, you can add a drug called bisphosphonate, and they're drugs which help make the bones more resistant to cancer spread and also help your bone density in the process. Why doesn't everybody get those? Well, they're designed for postmenopausal women and are currently not on the PBS. So there are some circumstances where you might need to pay for the drug or even for its administration. If you're not at Bruce Place at Peter Mac, where everybody gets these drugs. And that's an example of something that advocacy needs to change so that women around the country can have the benefits of research. Lifestyle factors you've heard about already: exercise, alcohol, weight, much harder than taking a drug. And if you have depression, it's really important that that's treated, but treated carefully by someone who understands that antidepressant drugs can sometimes interact with hormone blocking drugs and reduce their effectiveness. And so the person who's doing that needs to understand what's the best possible medication for you. Now, in the context of metastatic disease, for people who have either breast cancer that's spread at the time they're diagnosed or that comes back later, clinical trials are very important to consider. And we generally subdivide patients with different kinds of tumours into these 3 groups: hormonal, HER2 positive or triple negative. In hormonal breast cancer, recent studies have shown that combining a CDK inhibitor with aromatase inhibitors, so 2 drugs better than 1, but if that has stopped working, then there's a really interesting clinical trial that we're running called CAPTURE, where identifying in the blood, is there a mutation in the DNA, helps to work out what the right treatment might be. Similarly, there are new drugs coming into the treatment of HER2 positive breast cancer, tucatinib, DSA201, and in triple negative breast cancer, immunotherapy, PARP inhibitors, etc. So for metastatic disease, people don't usually have just a one-off therapy. They step from one treatment to another. And it's really important to consider quality of life as well as effectiveness of treatment. And that's something that we're really committed to at breast cancer trials. So in the metastatic breast cancer world, some years ago, maybe 2 years ago, brought together a group of people interested in this work in Australia. And in metastatic breast cancer, one of the challenges is awareness in the community. Multidisciplinary care planning, which is normal in early breast cancer, has to be done differently in metastatic breast cancer. Data has to be done differently. New therapies that are proven in clinical trials have to move quickly into the treatment center, affordable treatment, and that's a challenge. Breast care nurses, different skills, and we know that care professionals aren't always the perfect communicators, so increased training. But one of the challenges is also to achieve better access to clinical trials, and I'm very much hoping that the experience of COVID will identify it for women in regional and rural Australia, but a lot of this work could be done in a more distant way over telehealth rather than having to drag patients into the city for all of their clinic visits. I'm going to stop there. We're a tiny bit over time, but Anna might have some questions.
Yes, I know we're a little bit over time, but we have received quite a lot of questions about breast cancer recurrence. So if you don't mind, I'd like to ask one of the questions which seems to be a recurring theme in what's coming through. This question is from Sarah, and Sarah has asked, what is the gold standard when it comes to monitoring for breast cancer recurrence?
Oh, look, I'd love to say there was a magic test, but there isn't yet. And so the gold standard really is mammography and ultrasound if appropriate. A doctor who listens to you and examines you carefully and orders tests when they're appropriate for whatever symptoms you have, rather than just treating you as a routine, click, click, click. That really is the gold standard at the moment, but I'm suspecting that that's going to change. And in the future, the hope would be that if we can identify people who are at the most risk of recurrence, we do have something in the blood that we can monitor to say treatment's working or on track, or we need to change things. We're not quite there yet, and the clinical trials that we are doing where we collect those translational research samples are going to be important to try and answer those questions.
Well, I think you've ended on a message of hope there, so thank you for that.
Absolutely, and yeah, I think things are changing. I think we're all feeling like we're taking our pills today, so we're all feeling Leslie quite happy. Yeah. But things have changed an enormous amount over the last 30 years, because not only of clinical trials being done, but of their results being implemented. And that requires knowledge, it requires training professionals, but it also requires advocacy. And that's where you, as people interested in clinical trials, can really help us.